4?
4.5 years.
4.5 years. See, I got it. And is going to be mentoring our Cole fellows. And a man who needs no introduction, Darius Mashvegi, joining us from Stanford. Darius actually did his fellowship here many, many years ago at Cole Institute. It's the exact same place, right?
Live from campus.
Darius, Darius, incredibly well known in the world of pediatric retina, entrepreneurship, safety, lots of great things I could say, development of novel therapeutics, and taking excellent care of patients. So that's it. We're going to start.
Don't forget allergies.
And allergies. That's it. We're going to start with Hung-Ween Hua. Hung-Ween has been a phenomenal fellow here at Cole. Hung-Ween did her training at USC and came to us 2 years ago. Hung-Ween, take it away.
You're muted, Hung-Ween.
Yeah. So clearly we haven't learned in 2 years how to unmute.
I've learned nothing from COVID. I've learned nothing from COVID.
Zoom etiquette needs work.
Yeah. Hi, everyone. My name's Hung-Ween. I'm one of the senior retina fellows, and it's a bittersweet moment. We're the first class of 2 years of Cobra, and I am excited to share with you my surgical case, finishing fellowship. The sky's the limit. It was a very exciting case. All right, so we start the case with a 16-year-old man with a past ocular history of a gunshot wound to the right eye, resulting in a ruptured globe, and had a globe repair a month prior, presenting to the retina service at our county hospital. The patient had a corneal scleral laceration, uveal and vitreous prolapse at the time of the globe repair, and the CT had axial cut.
Could you tell me a little bit about what your normal, like in terms of seeing like a globe patient, like when would you prefer to see patients after a globe like this? Is a month pretty typical?
I think a month pretty typical. We can't to act on something. Seeing them the week after the globe repair is nice, so that you can make a surgical plan and monitor them as they hopefully improve and decide if they need any surgical retina intervention. But in terms of acting surgically, a month to maybe a little bit longer out is a pretty nice time frame.
So Kat, is that Prithvi here? Sorry, I'm just joining the fun late, but so the old teaching would be 2 weeks, where you do the repair, and statistically speaking, the development of a spontaneous PVD, if it didn't exist, usually occurs around that time. Obviously, so many other factors come into play, but what 1 month is comfortable because the eye is more quiet, but is that too long?
Yeah, I think that's a really good question. And I found that this depends a little bit, I think, on where you train and sort of what the culture is. I spent some time doing some open globes when I was a chief at Mass Pioneer, and Dean Elliott drilled into our head that the perfect time to intervene in these cases is between 10 and 14 days after they had their injury. And we had like a really robust system for getting them plugged in right away. But the eyes are often healing a lot, and I've seen more at other places sort of waiting a little bit longer. Do you guys have a set protocol you do at Stanford? Is it sooner than a month?
I try to send all these patients to Darius.
And I turf.
Well, he's 16, right? He's peds, right? It's peds retina.
Yeah. However, I can get him in this clinic. So no, I don't think we have a set protocol. And I think, your experience at Mass Pioneer, which has, it's kind of built for that type of trauma situation. And I think, urban setting versus not all taken together. But I think for me, it's how good is the cornea? How good is the view going to be? And just because you hit a certain time mark, that may not be good enough. But I think, as Hung-Ween said, they get sent in, you see them, as soon as you can, and just start laying the groundwork for the future, which is going to be more surgery, more likely than not. And that timing, I think, depends on what you see on day one.
The single greatest benefit of 2 weeks in a kid is that the family starts to understand that vision may not be coming back.
I think there are always other extenuating circumstances with trauma patients, and there are either other injuries or social issues and such that sometimes 2 weeks, you can't get everything set up. So I use the V scan often to help guide me, but oftentimes they're getting through a mental part of this, and going back to the OR is not necessarily the best thing to do quickly.
Yeah, I think those are good points. These cases are always really complicated, and it's easy to come up with sort of your general rubric, but you know, you have to take the patient in front of you. But it sounds like this patient first came to you, Hung Nguyen, about a month after the injury. So why don't you tell us a little bit about sort of what you saw and sort of what your approach was going to be?
So you can see here that the eye was not, this was a presentation to the ophthalmology service at the initial time of open globe, and the right eye is essentially deflated. I mean, the lens is in, seems like a decent position, but they actually did a great job in repairing the globe, as I'll show you here soon. Prior to the globe repair, the patient was inconsistently light perception, and afterwards they were consistently light perception, and their IOP was on the lower side of 5. And this is what their exam looked like. You'll see in the video that the cornea was edematous, had a C-shaped laceration with 10-0 nylon along it and some corneal edema. The anterior chamber was shallow temporally, otherwise quiet, and there was some iris incarceration into the wound, and a little bit of iridodialysis nasally. And the lens appeared anterior subluxed with some anterior prolapse of the vitreous. So if you look here, you can see that this globe is much better formed than that CT had showed, and that there was concern here. We don't have a formal ultrasound team, but there was concern at the time of the B scan a month out that there was shallow anterior choroidals and an area of superior shallow retinal detachment as well. So there's a lot of things going on in these complex surgical patients, and we discussed prior to the surgery what our plan would be. We have to address the cornea. This would be a multidisciplinary case with multiple subspecialties with a corneal specialist on board for a TK, PK. We would have to address the lens if it doesn't provide a good view. The retina appears detached, so you know, then you discuss, oh, is a buckle a good idea? Well, in the setting of a TK, PK, probably not. It's a young patient. They may have adherent hyaloid. You have to also consider other complications like membranes, PBR, tractional folds, and what type of tamponade that you'll put in. And so ultimately, we ended up definitely planning for the TK, PK, vitrectomy, and then likely taking the lens as well, and then deciding for a tamponade intraoperatively. So,
I really liked how you highlighted those issues, because I think the cornea, as Prithvi sort of alluded to, is one of the key parts. Is, you know, knowing this case is probably going to be long, and just what's your visualization plan. So I think that's great. You planned that out in advance.
yes, absolutely. All right, so we can see here that there's that C-shaped laceration with the nylon sutures. And so Dr. Steinemann, our cornea specialist at our county hospital, removed the sutures and then took off removed the cornea and put a temporary keratoprosthesis on, suturing it in, giving us a view. You can see that the infusion cannula is already in place. And now I'm placing the trocars in. And look at that, for the first time, we have a view of the retina.
Hey,
and it actually, yes.
Wayne, so I'm gonna stop you for a second. So you've done a few of these now. So what are some challenges in terms of getting just the trocars in, and what are some approaches you can use if you struggle with getting the trocars in when they're open sky or they've got the TKP on and it's not really watertight?
Yeah, that's a great point. You can, I think, putting in the grabbing right where you want to go, and then giving yourself counter traction right at the place of the trocar. And then if you can't get a view, consider getting a 6mm so that you can get the infusion in place. But we put in the first trocar in so that we could give ourselves some pressure just in case. There was difficulty at the time of the putting in the TKP so that we could get the pressure up in case we needed up for the second and third trocars.
Yeah, this is great. And the other thing you can do is actually just take the NBR blade and make a sclerotomy and then insert the trocar through that in case the eye is really softening or really struggling with it.
Mm-hmm.
I'm a big fan of intraoperative ultrasound at this moment too. You did a good ultrasound pre-op, but sometimes, you know, you think infratemporal will be the best place to put your port, but it may not be, right? If there's a big detachment or choroidal there, then you may not know it. So really taking the time to do a good ultrasound to see where you need to be, I think is helpful. What kind of TKP was this?
That is a great question. I don't remember the name of it. Dr. Yoon, I think, is on the line. We graphed it. It was, I want to say it started.
It's on Landers. It's
Landers.
on
Landers.
Landers.
That's what I said with an L.
I think
Yeah.
there's only really one trick question, but
there's an Eckert as well, but those are the only two, the Landers and the Eckert. That's it.
So the question, Hung-Ween, is so for those of us that may not have operated through this, any tips on what you put on the surface, like how quickly like that dried out? Like, was it just you put it once and you're done? How clear was your view? Any adjustments?
Yeah, TKP is a beautiful view, and it actually show a clip at this point in the video of several ways we tried to address the view. Ultimately, in the end, we decided that actually having no viscoat on the surface was better. But there are points where I tried to see if viscoat would help, and it turned out to be that the view without a surface lubricant was quite good. And so now we're putting in Kenalog. Oh, sorry, did you want to add something else?
Go for it.
Okay. So now we're putting in Kenalog to stay in hyaloid. I was curious if anybody has votes, given that this is a 16-year-old young gentleman who had you know, an open globe repair. If you think that the hyaloid is up or down, we had discussions during the case, you know, given that the patient had trauma and vitreous prolapse, there's a likelihood, even though that the patient's young, that the hyaloid might actually be off. And so to Dr. Mrityunjaya's point, the viscoat ended up being more of a barricade to a good view. So we took it off, and it turned out that the hyaloid was up when we checked with Kenalog, which was important to check. So now now I'm doing a peripheral shave. I'm looking for the break and realizing that the patient has a nasal detachment. The patient's very lucky. And looking for the break within this area of nasally detached retina. And to help us is we're putting in some PFO. And we're realizing that this patient has dialysis, which is not surprising given that the pathophysiology of the trauma, that he's a younger adult. And so at this point, we're deciding whether or not we're deciding that we should want to take the lens. And I wanted to poll, Yar, if we could cue the poll, the audience, on how you would take the lens in this situation. So we'll give you a minute or so to answer the question. How would you take the lens? Would you leave it, given that their view is pretty decent? Do a pars plano lensectomy after a core? Do an open sky cataract extraction prior to the core or after the core? Was wondering what everybody's thoughts were. I'll give you a few minutes here, or a few seconds.
Can I ask
whatever makes the most impressive surgical case or surgical video?
That's always a good choice. So, I mean, the reason to take the lens was because you wanted to improve your peripheral view. Was that the reasoning, or it was already becoming a cataract?
It was, yeah, it was already becoming a cataract. It was anterior sublux on the initial exam, and we wanted to get a really good shave in. So, and the view was kind of going. So for all of these reasons, we decided to bite the bullet and say we need to take the lens at this point. And I was really excited, and voting one way or another. You'll see in a few seconds how we decided to proceed, and I think that it went really well. Does a poll show live results, or do we have to release the results?
It's not live. I don't know. Oh, here we go.
Okay. All right. So it looks like most
No consensus.
people, yeah, not a sure consensus. All right.
Only 4 people voted. It's fine. You know I'm just messing with you. I think the good news is there's lots of different ways. It's a young person. It should be relatively easy to take this lens. I think your view is pretty good, but let's see what you did.
You looked really good.
So to be the contrarian here, I would have gone in, brought my hyaloid, you know, saw that it was up, and then I would have gotten out of the eye, pulled my ports, put a buckle in, and gone home. Kept my lens.
I like it. So tell us why, Darius.
Well, first of all, that lens is going to be fine if you leave it alone and you stay out of there. Even if it goes white on you, they'll turn back. The kids are remarkable in that regard, okay? I've been burned so many different times on that after a while, I just said, I'm not taking the lens. I'm not taking the lens. Okay. And you just have to stick by your gun on that. Second, you have a dialysis. Why are you doing a vit? Why are you going to shave the vitreous base? You do your buckle, doesn't matter what's out there. This will fall flat. You'll be good to go. And if it doesn't, then you can come back and do all this. But you take the lens on this kid, you're dooming the vision in that eye long term.
The issue was the cornea as well. In putting in, we thought that the putting in the buckle after TKPK would be a bit more challenging.
That's fair, but
yeah,
I would leave the lens always.
I think those are great points. We decided to take the lens because preoperatively the lens did not look stable. It was partially subluxed. Preoperatively, I agree the view's great, and ideally we thought about putting on a buckle. Even initially we thought about putting on a buckle, but we thought with the PKP that would be difficult. So we decided, and they didn't have a what do you call those rings? A fringy ring, I think it's called. Yeah, they didn't have a ring to help stabilize the globe. So we decided, and we didn't know about the dialysis until we got in there and took a good look. So we decided, since we could not.
Yeah, I don't fault that at all. Because you go into the eye and you see what you have, but then you can come on out and run away. I can tell you, more trouble has been caused by being in the eye of a young person than not being in the eye of a young person.
I think those are all great points. And we just thought, if we're not going to put on a buckle, then we better get a good shave, a good anterior shave. So that's part of the reason why we decided to just take the lens.
Go for it, honey.
having the discussion. Okay, thanks. All right, so I'm sure you can guess what we did. Is the music going through?
You should sing it for us.
You can sing.
I'm not
yeah.
getting any music, but you have a good voice, Hongween. I think you could pull that off.
Let's see if I can reshare this.
Hongween specifically asked
Okay.
anyone to pay attention.
By the way,
to play
this was a 20-minute discussion during as we're talking about
Oh,
what present.
So ultimately, I was very excited and really wanted to attempt this open sky technique. And I think at the end, it was the most efficient way to take out the lens. The surface was a little scratchy again, so I tried to put on the visco to help the view here. And here I'm doing the rexus on this very loose, you can tell that the zonules.
If you're
aren't
going
doing
open
great.
sky, you absolutely, once in your life, have to shove the cryoprobe in there and go for it. I've done it. It's spectacular. It'll change your life.
Yeah, because the good old fashioned intercap, man, would be perfect.
Couching.
That's great. That's great. So here I'm doing the rexus.
I'm not sure it changes your life for the better, though, Darius. It just changes your life.
And I decided to leave the TKP on during this part. Many videos you'll see for Open Sky that they do this without the TKP or TKP on because they're not planning for it. But it gave me better surface tension in order to do the rexus. So that was a nicer part, especially in the setting of loose zonules. It was better to leave it on for this part. And then next I'm going to do the hydrodissection in order to burp the lens out. And finally cutting the sutures to Open Sky cataract extraction.
Ooh, that's awesome.
It's very satisfying.
If Hongween gets to give her pearls about what she learned as a fellow, I'd like to give a pearl about as a young attending that second year fellows sometimes are a little cavalier with what they recommend. And while they have the surgical skill, sometimes I'm like, you want to do what? I've learned to listen
And say no.
and say no.
Hey, it was an efficient way to get the lens out in this case.
So something else.
For every beautiful Cobra case, there's the complication we don't show, right?
And again, to be like completely, frightened in an eye that's just had trauma. I mean, you're opening the TKP. I know you got a good infusion going, but there's still going to be that risk of, perfusion change and pressure change and suprachoroidal hemorrhage. And along with the girl could have been like something else that came out as well. So, I mean, you may not be able to avoid it. You're watching your infusion closely. You could throw in, you could even, would you consider putting perfluorocarbon down just to hold things in place? You're already kind of creating a
There was already
more complicated situation. Okay, so I mean, I think that's just something to keep in mind, that there's something.
Prissy,
that
do you think perfluorocarbon stops the suprachoroidal hemorrhage?
No, but like before the blood comes out, the perfluorocarbon will come out, and then you'll know, I guess. But no, I don't think it does. It's just I'm just trying
Makes
to
you feel better.
The stabilization.
All you get
I
is
guess
like
I just
bubbles.
I just worry about like opening that TKP like at that point and then having to put it back.
It's Cobra rounds, man. Come on. Let's congratulate the
this is beautiful.
Nice work.
Beautiful.
We also
There was
didn't
an
open
effusion
up-
in the eye, to be fair.
Right, and we also only opened up like probably
It was like
6 clock
less than
hours
a
of it.
minute. Yes, exactly. It was only partially open.
That lens
right,
looked
so-
pretty clear. I'm
Yes,
just saying.
it was.
Yeah, that
it
was
clear
completely
but
clear
unstable.
lens.
Yeah,
you
it
could
was.
have
It was an
aspirated it
unstable
with just
lens.
the cutter in there, no cutting, just aspiration. It would have come all in.
Steve Stanislaw
Yeah,
made the
fair
same
points.
point in the chat that an
That's a fair
alternative
point.
would be the aspirate.
I think we definitely could have taken this with a cutter. Yeah, I agree with everyone, but
You wouldn't be showing it today. That's why.
yeah, we thought we could probably take it a little bit faster, maybe.
All right, so now we're doing a fluid air exchange. And the capsule was giving us problems at this point, so decided to do a posterior capsulotomy.
So Darius, is there like a good reason to keep a capsule in a kid? Like if you didn't want to take the lens in the first place, is it worth keeping capsule?
Only from the perspective of removing it entirely introduces its own set of problems if you're not paying attention.
Okay.
Particularly in a patient with a dialysis. So, but I would leave it.
All right, and fill in the eye with C3F8. And thank you, Dr. Yoon, for a great case.
Nicely done,
All
Hung
right.
Wei.
Nice
Congrats.
case, Hung Wei.
Thank
That's
you.
beautiful.
All
right.
Beautiful case.
You got a pearl. You got a one pearl for everybody.
Yeah, let me share my post-op course and show
sure.
you that the retina is attached with a good result. So the patient post-op month 1 was hand motion and the IOP was 9, and thankfully the retina looks great. Unfortunately, there seems to be a subfoveal pigmented scar, but compared to where the patient started, the patient's doing great. So my pearl from graduating retina fellowship is that retina surgery is very humbling. In the first 6 months is all about visualization, and yes, you will cry over some difficult outcomes, and there are some days that you'll say, maybe I'm not cut out for this, but it doesn't mean you're a bad surgeon. Hang on there. And then my 1.5 pearl is to practice with the scope in the vitrectomy pedals, maybe like the week before going into the OR, to feel really comfortable with it, because really that's the first struggle starting to learn retina surgery. Thank you.
Very nice.
Well done.
Well done.
Nice job.
Are you guys going to sign her certificate? She's going to graduate?
I'm waiting for the song. Until I hear the song. We have to wait
No
for her.
song.
She has to sing.
All right, Hattie,
No
drop
song.
the beat.
But yeah, Hadi and Hung Wei have this like duo rap thing, which no one goes and sees. So we will have it at Cobra. At Cobra after hours. Sorry.
We have a very supportive department.
Take it
That
away,
was great.
Prithvi.
Yes, thank you. So our next presenter is Dr. Suzanne Mikulak, who is a soon to be graduating second year fellow here at Stanford. Suzanne's going to be heading back east and joining the faculty at Dartmouth, and expecting a busier and fuller house in a few weeks as well. So we're really happy for her. She'll be discussing a case that she did with Diana Doe, and Dr. Moshfeghi will be mentoring her through it. Good luck, everyone.
Thank you. Okay, so this was our patient. It is a 47-year-old female who was referred by an outside optometrist for an abnormal retina exam and decreasing vision. On exam, you can see she had retinal vasculitis, no known history of any inflammatory disorders. She had a huge inflammatory infectious workup, as well as genetic testing to evaluate for possible fever. All of it was negative. On exam, she also had the schisis, you can see, and as we followed her over the next few months, she had progressing schisis towards the fovea, which was symptomatic. This is not actually the surgery
Stop
that
there for a second. So when you say she was symptomatic, first of all, I wasn't convinced on that it was all that progressive. I think we had talked about this previously, but when you're thinking about doing surgery on acquired retinal schisis, what are your typical thought processes for, surgical intervention? I mean, is progression towards the fovea the top of your list?
It's both progression towards the fovea, which is vanishingly rare, but they say sometimes happens. It's almost always stable. And then if it does happen, they say it's very similar to fixing any other kind of tractional detachment or any kind of other retinal detachment if you're going to go after fixing the schisis, but usually you try to avoid operating on it. This patient, her vision was decreasing from 2025 to 2040 over this time period, and she really felt like she was having changes, which I know we talked about before is maybe she was, maybe she wasn't, but it looked like on the OCT, it was pretty convincing.
Hey, Suze, can I ask a question? You mentioned retinal vasculitis. You guys do a fluorescein? Was there a lot of leakage and such? Was this patient immune suppressed or put on steroids?
Now he's
or
awake. You said vasculitis.
Yeah,
I'm always awake. I'm always awake. But you said that I always get a little excited.
There was an FA done that showed optic disc leakage and diffuse capillary leakage, as well as macroaneurysmal changes and late vascular leakage. Before surgery was proceeded with, she was started on oral steroids as well as oral Diamox to try to decrease both the schisis and prevent the progression of it. But despite that, she started on that in July when we first saw her, and despite that, she continued to progress.
Gotcha. So before we get to Eddie Karat's excellent question, if my startups all fail, I'm going to be working for either Medicare or Blue Cross Blue Shield. In 5 years, you're going to have to justify every surgical intervention that you do. And the grumpy old guy who's going to be sitting there is going to be someone like me, if not me. And I get paid to say no. And so I actually found there was only one really good case series, and that was by Bob Watsky's group, where they followed 7 patients over a 43-year period. And interestingly, when the foveal schisis, when the schisis went on to directly involve the foveola, those patients retained visual acuity. Okay, it was only patients that had a combined regmatogenous retinal detachment and retinal schisis component with subretinal fluid in the fovea that actually did not maintain visual acuity over time. So preoperatively, I would say that you have a relatively weak indication, but let's see how your surgical approach goes. And it brings up Eddie's question, which was there a pre-existing PVD?
All right, so the first surgery, so there was a pre-existing PVD. It was kind of right, but it was very localized. There was still hyaluronic mostly down mid-periphery and beyond, but you could see, you can't see in any of the pictures, but you could see on exam there was a central kind of PVD, but not a complete one by any means. So a scleral buckle was done for the first surgery, and everything was stable for about a year. And then we saw on OCT that there began to have this subretinal fluid that was now actually encroaching upon the fovea. As you can see in August, there was no subretinal fluid. December, there was a little bit more. And then January, there was much more. At this point, her vision had decreased from 2040 to 2080. It was getting dangerously close to the fovea. So we decided to intervene with another surgery. And that's the surgery that I'm going to talk about. She also had a PSC cataract. As you can see in this image here, it was, the images weren't that pretty because of that. So we decided to do a combo cataract surgery at the same time to improve the view. There were some little interretinal holes over here. As you can see, they didn't appear to be full thickness to us at the time, but we weren't quite sure whether this was all tractional or whether it was an actual rhegmatogenous component.
What were your goals of surgery?
The goals of surgery were to relieve the traction, repair the detachment.
Were you thinking retinectomy at all, or unroofing?
The schisis cavity? Well, I mean, I think it would depend if it ended up, if the holes were full thickness or not. I think it was very hard to tell.
Entertain putting barrier in there. I mean, you're pretty close. You don't have a lot of room to operate there.
Sorry, entertain putting barrier laser, you mean like in the clinic beforehand?
No, at the
Oh.
time of surgery, when you're going in to prevent progression. If that's what the reason you're going in is you're saying you want to prevent progression to the fovea, correct?
Yes.
And so I don't think that, I think kind of what Prithvi's getting at, and maybe I'm incorrect on this, is that if you don't unroof it, maybe it'll continue to pull.
Yeah.
Yeah.
And I think, you're so close to the fovea anyway. How far are you willing to go with cutting if you need to cut? I think that's kind of going into this. That makes me nervous. So it's like that healthy fear of like all the bad things that could happen when you go into a case like this.
Yeah, I mean, I think it's easy to feel stressed when you're seeing these cases in clinic as they're progressing and you want to go in and make it better. But then when you're there, it's hard to know what you can do to prevent it from coming back. I think like Beaumont published a nice series of just schisis related RDs a couple of years ago that showed that the single surgery success rate is like it's like not nearly as high as you would want it to be. And so when I'm in there, I always never know when to stop lasering, like what maneuvers to do. I think these cases are really tricky. And so I think, as a lot of people alluded to, I really try and avoid taking these to the OR unless I'm really forced to, because I just think there's not a lot of great options you have.
So when I think of forced, I think that you have a progressive retinal detachment. That's what I think of. And that's kind of what I want to hammer home. There's actually a very good case report on this at the University of Iowa. I think Elliott Sohn and company have that on. It's worth reviewing.
And would you consider this progressive and a good indication for surgery?
I would say it's
getting there.
Yeah, it's marginal.
Yeah, I think what you're hearing from the faculty is trepidation about what bad things could happen when you're trying to do good here, because this is a tough case. So I think as much as you can be absolutely sure it's progressing and her vision is going down for it, because everything's going to go great, you're going to show us, but other things can happen. So I think that's the hesitation.
The critique is not that you did the surgery at all. We've all done this surgery, I think, and what you're hearing is that it's not a surgery I would recommend doing a lot.
Yeah, I'll tell you also that in the setting of uveitis or in the setting of ischemia, or where you're not sure, that I will significantly immune suppress these eyes for weeks to months before jumping in, because I do think some of the progression sometimes is a leakage or some form of the inflammatory component, and sometimes you can actually reverse it. But especially post-operatively, these eyes get super hot afterwards, and having something on board ahead of time. So I think in the chat, someone mentioned periocular steroids. I tend to look at these eyes and try to decide if they need systemic immune suppression or something a little bit longer acting in order to kind of get them ready.
That's a great.
Yeah, I think this is a hard case, regardless of which way you're going to do it.
And she had
So
been
I'll
on
make it-
Humira. She'd been on Humira for about a year now, and there was much
Awesome.
less leakage on the FA, and it was overall the vasculitis was pretty quiet at this point. So I started with cataract surgery. I just skipped to after it. Started the vitrectomy. The hyaloid was pretty up nasally, but temporally kind of over the schisis cavity. It was very adherent. So went back, cleaned up all nasally, then came back to temporally and was trying to lift it gently with the vitrector.
Did you consider using plasmin in advance, spinning it down yourself?
What? Yeah.
Sorry, plasmin?
Yeah, to further separate this. The biggest problem I have here is that you can inadvertently cause a giant retinal tear and then you get bleeding and then you've got this hot mess on your hand. That didn't happen, but it could. That retina there is very thin.
Yeah, I've heard of that. I've heard of people using that before, but I've never actually seen it done. I don't have. Do we ever do
you
that?
still have do you have a centrifuge still in the in the Byers?
We're
Yeah,
selling
we
it to
do.
anyone who's doing development.
We do actually have a centrifuge.
I can't wait for Darius's next question. Or you see about we're going to look for an instrument we haven't used in a while.
And then we switched to forceps to try to elevate it, and the hyaloid peeled off quite nicely. So I guess I got very lucky that it didn't rip. In this whole case, I expected the retina to rip at some point. Cleaned around the break just to make sure we got everything off, and then went for this anterior contracted hyaloid and tried to peel that off.
So why are you peeling here as opposed to shaving? Because it just looks like you're pulling your retina up.
I think it would have been probably reasonable to shave in this area as well, because I think the main goal was to get the highlight up over those holes, in case they were full thickness. So it's a fair point. Could have shaved this anterior stuff because it was all anterior to the buccal and would have been well supported anyway. So maybe it was a dangerous fellow move to peel that.
So what instruments you have here? Just a forcep, max grip, or
yeah, max grip forcep and the light type. And since this case, I've learned I like the ILM forcep more because I think I can cause more damage with the max grips. But at this point, I was using the max grips.
I think we discussed when we looked at this before, bimanual technique may have been helpful too with a lighted pick if you're trying to be as atraumatic as you can over that peripheral stuff. You're pseudophakic anyway, so you have that ability to reach wherever you want. But sometimes then you can just get it up enough and then shave without having to feel like you have to get the whole thing off.
Yeah, and when you go ahead here, hit play for the next 10 seconds or so, it looks like you're gonna start pulling towards the fovea, which is absolutely the wrong direction you want to be pulling if you're trying to avoid the schisis and the fluid going into the fovea, correct? Unless I'm upside down.
No, so you would have pulled temporally instead of nasally.
I would have come in with my other hand and pulled up. I wouldn't have pulled, I would have shaved. And I don't want to, the trouble I'm trying to prevent, it almost looks like you're daring it to cause that problem.
She's bold.
Yeah, I think one of
she knows she can handle it. She knows she can handle it.
I think this was all either going to be on the buccal, not anterior to the buccal, or a little bit posterior to it. And I think the fear was that if we didn't get this membrane off, then the retina wouldn't relax and that we wouldn't have fixed the tractional component. So
I agree with that. But when you look at your photo right now, you can't see where the macula is because everything is bullous over it. That's not happiness. Right?
A little PFO there maybe might have been another way just to at least protect. And, and like maybe third hand holds it down a little bit as you're trying to lift up. Yeah, maybe bimanual as well. Did I say that already? Bimanual.
Yes, that would have been useful. I still have a lot to learn. But after we got all those membranes off, the retina was a lot more mobile, which I thought was a good sign. And the fluid wasn't in the macula, but I guess again, it would have been nice if we had put PFO down to protect it. I think good idea. So we marked these breaks, which at this point in the surgery, it became apparent that they were just full thickness breaks, because we could see that from the beginning. I'm not sure if I mentioned that.
I'll
So we
be
also
the
got
center
lucky
on
that
the PFO, particularly in such thin retina, and then with the schisis, that PFO can end up under the retina very quickly.
Yeah,
It's a good point.
yeah. If
And
you,
then you've got a
inject
hot
too
mess
hard,
on your hands.
I think as Dr. Talcott alluded to earlier, we got lucky that there wasn't an outer hole that we had to search for and find, and that they were just full thickness holes. We didn't have to unroof the schisis cavity. So then we did the air fluid exchange. Again, there's a pretty posterior, what ended up being a posterior drainage retinotomy that we had. And then the retina flattened really nicely under air. And then I just
look at that. Nice.
switched hands to make sure it was drained completely dry, and then
That's falling on the
laser.
buckle pretty nicely.
I think it was a
Real
little,
close to.
and then
Real
we
close to
lasered
it.
all the retina anterior to it, because it was all poorly perfused on the FA anyway, all that temporal. And then we put in oil.
So why'd you put in oil as opposed to gas in this eye?
I think you probably could have gotten away with gas. But I mean, I think given all the persistent inflammation in the past, the extensive PVR membranes, I was just nervous that her risk of redetachment was high. Also, since the single success rate, as I mentioned earlier, is about 50% with these kind of detachments. I just thought it was safer to put in oil. So I guess I did some risky pulling moves, but I wanted to be at least safe with the oil.
Wanted to keep the retina on.
I think that's fair.
No, I actually think it was a cool case overall. I just, I'm glad that I wasn't the one in there.
So Eddie Korot asked a question. Darius, want to take that?
Let me see it. Which question was it?
He was asking about visco dissection of the hyaloid. You brought up using
Yeah.
plasmin.
Yeah, I
So-
can tell you, I've tried that on these cases also, and you think it's an easier tool. I did not find it to be. I think one thing that I never tried on these cases, if you go and read in the literature, they talk about TANO in acquired foveal schisis retinal detachments. I would have loved to have used that nitrile loop from Alcon. I think that would have been, I would use that, something that I can control both where I'm placing it and what the general force relative to the retina is, as opposed to the visco. You could shove it in there and next thing you know, you could blow a hole in there just like when you're pulling. And so that's why I wouldn't use that. I think it works spectacular for very good mature PVR with thickened retina and also in diabetics, like Baker Hubbard is showing. But in this case, I'd be very scared.
I think you're also fortunate with how stiff that uveitic inflamed vitreous was. It was elevated, and just as you were releasing it, it kind of looked almost diabetic in how it came off. And I wonder if that hyaloid was more attached than it was peripherally. I think this could have been a different story. So, I think you managed it, really well. I think we're all just scared for what could have happened, but it didn't. So well done.
Yeah, it was a great case. Nice job, Susan.
Beautiful outcome.
Thanks. And then
Yeah,
patient's
that's
still
awesome.
attached 4 months
I had-
later. I'm happy
Sumit,
with.
I had a question, Sumit. So if I wanted to use longer lasting steroid therapy on this patient, I wanted to inject something in the eye. What's the do's and don'ts in an oil filled eye for like a dexamethasone or a fluocinolone insert?
I think you're okay with either. I don't know why you want to in this eye.
No. Well,
I think you want to
again,
avoid
there's
it here. But in terms,
Right.
in general, in terms of an oil-filled eye, because it'll go into the oil phase, I think you're okay with either of them. I don't know if there's not great data in terms of large series of putting it into oil-filled eyes, but you wouldn't have a problem putting it into an oil-filled eye.
So how long are you planning on keeping the oil?
I don't think we're in any rush to remove the oil.
Until
Patients,
the end
That's
of
going to
her
be your
fellowship.
big problem.
Until
Okay.
her end of fellowship, and then
Yeah.
yes.
She's like, see
It's
you
not
later. I'm out of town.
Yeah, it's been about 4 months, and I would think until the oil starts causing problems, we'll probably leave it in. Would be my plan for her.
Tomorrow morning.
Tomorrow.
Keep it in. Got it.
Yes,
No
keep
rush
it
to
in as
take
long
it
as
out is what
possible.
you're saying. Yeah, this looks good actually.
And we did give her 1 gram of IV solumedrol at the end of the case too, to kind of prevent some recurrent inflammation afterwards. Vasculitis has stayed quiet as well in the postoperative period, which has been
So my longest case is now 20 years, I think. And I just saw him a couple of months ago. And I took the oil out at 6 months against my better judgment, and he has stayed completely flat that entire time, and I never went into the other eye. Okay, so I operated on the right eye. The left eye had the same thing, and I just left it. He had a localized retinal detachment, but it was asymptomatic. I didn't do barrier, nothing, and he stayed. Eventually, that whole thing collapsed down on itself in the left eye. And the right eye, once I took the oil out, he did great. And so it's nice to have the ability to observe these things over time. When you go and read that Watsky paper from 2013, I think, in retina, they have 43 years where they're looking at these 7 patients. Now, it wasn't 43-year follow-up, but over that time frame, they had long-term follow-up on these patients. And I think what I'm trying to hammer home is that sometimes, unless the patient is supremely symptomatic and moving rapidly, there's a lot to be gained by doing nothing.
Very good point. Yeah.
The senior surgeon says don't operate unless you have to.
Susan, any pearls of wisdom for those who are watching?
Oh, my pearl of wisdom that I was going to give is very similar to Hong Ween's. It was always fix your view first, I think, is the main thing that I learned during my first year, and that during my second year of fellowship too, because if you can't see, then you are going to make mistakes and bad things are going to happen. I think so.
Yeah,
usually possible to fix it somewhat.
Good luck to you in the Northeast. Looking forward to your success.
Thank you.
So our last presenter today, Charles, you up? This is Charles DeBoer. Charles is finishing his fellowship with us about a month or so. Charles will be staying on our faculty, joining our K-12 program and working on all his innovative stuff. So looking forward to having Charles back on the Cobra on the other side in a few months as faculty. So Charles, take it away.
All right, thanks so much. This is our senior send-off. This is a case. So I picked this case. It's a series of 3 surgeries. We're going to show the first and the last one. And it's there's some surgeries that followed me through fellowship. So we started as first year fellow taking care of this patient. And we had some setbacks and moved forward and brought him through. And what kind of started out as a patient ended up as a patient, but also as a friend of ours as well. So it's a 62-year-old male who had a history of ocular trauma, had basically had like a motor vehicle collision and rolled over and had an orbital fracture. And then subsequently had a retinal tears and had laser retinopaxy and was stable, but then had come in with some vision loss of that eye. So we had seen him, he was referred to us from an outside provider. Vision was hand motion, pressure was controlled. And this is kind of the surgical view, but this is what we saw. There's basically a total retinal detachment of his right eye.
Charles,
and there's
let's back it up a little bit here. Did you guys A, perform the retinopexy, or B, see it prior to this presentation right here?
No, never. Basically what I had is I had a call from one of our referring providers, and he let me know sort of the history, and he said like they had done retinopexy before. They had felt like that he had been stable after that, and then had came in sort of with this basically total retinal detachment with proliferative vitreoretinopathy. But no, before this, I hadn't met the patient.
Alrighty, continue.
So, so we can see a significant amount of proliferative vitreoretinopathy and basically a total retinal detachment. So the plan for the surgery was we wanted to do a scleral buckle. This is a phakic patient to support the vitreous base. We're going to peel membranes. I wanted to leave the patient with oil. You could have done a gas or an oil, but I felt like oil would be better, just given the fact that I was worried that, you know, it's possible there could be recurrent detachment. I wanted a good tamponade for a prolonged period of time. But, you know, the other option, of course, would have been like a C3F8 gas. So we put the buckle on first and then went to the back.
Was it just a band?
Yeah, 4170 band, 3 millimeters back from the muscles. And so we start the vitrectomy. The patient had a posterior vitreous detachment already. And you can see as we kind of come through here, you can see the areas, the tears that had been lasered previously, which we thought.
The one thing, stop there, on the vitreous detachment already, people always just live off of that. And oftentimes it's just vitreoschisis. And we saw previously on the first case that they used steroid right off Hanwi. Did you think about using steroid in this case to actually ensure that you had this? Because you were talking about doing 3 surgeries. So I'm curious if you were controlling for that.
Yeah, I mean, typically we'll stain with a Kenalog. In this case, I don't remember if we stained or if we definitely checked by the nerve with the cutter itself, and then we're going to stain. We'll have Kenalog down later in the case. So we surgically noted it wasn't like preoperatively we had noted it, but it was also surgically that we noted it as well. Because to your point, we want to make sure that we're getting the hyaloid up. Especially in this case, and we want to make sure that we're removing the PVR membranes because that's what's going to cause us to have.
Just one last thing, though, that, you know, in my experience historically, was that it was easier to get the hyaloid up at the beginning of the case as opposed to later on in the case. So that's one of the other things I bring.
Good point. So you can see the tears, and then. And the buckle height, you know, it's a little difficult to appreciate initially. We tried to give a reasonably high buckle height when we did it. And then we're starting to peel. We're getting a little bit of peeling some of the PVR. Most of it felt like it was epiretinal versus subretinal. And we come around and we do a peripheral shave under scleral depression to stabilize the retina and mark the breaks. Then we decided to come back to the macula itself and try and peel off any residual PVR as well after we've completed a little bit more of our shave, and we're stabilizing. So we put down blue and then peel, because a lot of the PVR is intrinsic to, you know, is basically along the macula, and then we stabilize with PFO and we'll flatten the retina. And then put in laser around the tear. We also put a little laser on the buckle itself, basically coming around and fill with oil. So at this point, you know, our goals of surgery are achieved. But at postoperative week 1, you can see now we have these inferior foci of proliferative vitreoretinopathy, and so this kind of puts us into what to do next. I don't know if does anyone have any thoughts on what they would do next at this? You know,
so stop right there. Alex brought up a good point, which was he said he would have peeled the ILM during the case. Can you guys opine on your decision not to?
No, we peel. We're peeling.
You peeled? How far out did you peel?
So we tried to peel to the arcades. We obviously didn't get it peeled out as far inferior as we're having the PVR.
Alex, would you have peeled further, or would you have used stain in peripheral areas that were extramacular that you saw folds in to try to release that as well? People have described that.
I would have tried to stain as far out temporally to where those folds were, and try to get it as far out as possible.
Yeah, I mean, yeah, we did obviously spend a lot of time peeling and trying to peel out kind of as far as we can. It's a good
It
point.
was all ASON peeling, right? I just saw he joined the talk, so I figured I'd give him a shout out.
What type of stain was that?
A brilliant blue. So we could
Do
have
you
used
just
like
find ICG to work a little better in cases like this? I think brilliant blue sometimes is a little difficult.
I've become a blue fan, honestly. I feel like from a safety profile and using tissue blue to, peripherally, I think it really helps me to see these types of membranes. And I would have not necessarily put ICG down to peel ILM in this type of case, but I'm very comfortable going to blue now. And that distinction between, what's membrane or not, I think it's pretty good. So
yeah, I'm the opposite. I have not adjusted to blue very well. I love the green, and I don't know if it's just the way I am. It could be, but I just find my stain
you're a toxic person, Snail. I mean,
I think the toxicity was talked about a lot when we were much younger, and we were talking about 20 gauge light pipes. We were talking about a different lighting system, and with what we do now, I think we all use a very small amount. We put it in D5W. We use 25 gauge. We don't use the type of light source. I mean, sure, it's possible, but I think for a lot of us, I think there's also this just change in the tissue. I think it's just different. So I don't know. I still find green is helpful to me, and I know I should like blue. I know I should love it. Everyone tells me it's amazing. I still like green. It's just the way I am.
I thought most of those toxicity studies were in cells. Are there actual human studies
Can you
in
back it
vivo
up?
that
End of the case.
that shows the ICG?
No, there were case reports, Alex, many years ago that showed it, that described them. But the toxicity that you're describing was like the ones that were done at Emory years ago with Hans Gross class and Brian Sippy and a couple other people. But yes, they were in cell cultures. Anyway, we're tangenting. Back to your case. Sorry.
So were all the breaks inferiorly?
Yeah, there was a 5 o'clock and a 6 o'clock break. So basically it had broken through where the laser had been.
Yeah, and then this was 3 months after the original trauma that he came in?
He came in, yeah, his original trauma is about 3 or 4 months after the original trauma.
Are you injecting methotrexate at this time, or did you put methotrexate into the infusion knowing that this is a high risk detachment?
So for the initial case, we didn't have methotrexate in our infusion, but then, yeah, exactly. So that's exactly it. So we're gonna start using methotrexate now. And so basically we have recurrent PVR. We want to allow it to mature a little bit. We want to give the patient some time. We have a good tamponade with oil. And the thought is to keep the retina stable. We'll follow them weekly with weekly methotrexate injections with the plan at post-op month 1 to come back and attempt to peel membranes, but likely go for our second surgery. And because something that we always think about is what will be our second surgery if we have to do it. And here the case is, given room so that we can do an inferior retinectomy if we have to. So I talked to the patient about the risks and benefits of using it like an off-label methotrexate, and he agreed that he thought the benefit of it was worth it in this situation.
So you said this was awake, alert oriented physician. Is that correct? And do you happen to have any idea on what his preoperative visual acuity hard copy objective before the original injury was? Because it doesn't track that this person who is so, with it would allow the vision to become so poor before presenting in such an advanced state. I'm just wondering if there was a pre-existing disposition for having poor vision in this eye.
I don't think so. I think the vision was good in this eye before.
Yeah, but do you have objective evidence of that is my question.
No, I don't have the like objectively, I don't have the prior notes like from the other provider, so I don't have.
It's a good point, Darius.
I mean, he just presents like it looks horrible when he
Terrible.
presents, and it's just like, to me, it struck me, and I told Charles this earlier. It's just kind of like, I don't usually see that after retinopexy standard, and I'm just trying to figure out what would have changed this picture. I don't know. I mean, if it goes unchecked for a long time, sure, but that didn't build up overnight. No way.
No, agreed. So we do a series of 3 methotrexate injections, and you can see the PVR is worse, and the detachment starts encroaching in on the macula. And so we had planned at month 1 to do his second surgery, and so we had it pretty much scheduled, and we went and we did the retinectomy for the next surgery. So I'm not showing the surgery, but basically we had done an inferior retinectomy, a 180-degree retinectomy, incorporating the areas of PVR, and we provided intravitreal methotrexate during the retinectomy as well. A couple things to note. First of all, he did have side effects from the methotrexate, and he had this horrible corneal disease. He's taking artificial tears and lubrication. We tried to keep that on for him as well, but he definitely did have side effects from, what I believe to be the methotrexate. It's well documented. And then post-operative day 1, this is what he looked like. So I'd love to have anyone's thoughts. He's not having a lot of pain, but he has this hypopia on post-operative day 1. What would people out there, what's kind of the consensus on what you guys would do in this situation?
That's a large epi defect too, correct? I'm not missing that, right?
I don't think there's a large, I don't think he had a big epi defect, but he does have a hypopia. Not a lot of pain. He's got oil in the back of the eye.
And you guys injected methotrexate at the end of your surgery?
Yeah, we did.
So you have a hypopia in the setting of methotrexate, which is an immune suppressive medication. So this is either toxicity, over inflammation, or infection. You're obligated to tap and inject. I would worry about an infection, so I would personally tap and inject.
Yeah.
Even with the oil?
I tap the AC, Darius. I mean, if it's endophthalmitis, the eye's done, or you take them back to the operating room.
You're preaching to the choir, my friend.
Yeah. No, I
think you give half dose of the antibiotics, but you're obligated to tap and inject.
Or you go back to the operating room.
Yep.
That's your other.
Or you take out the oil.
You take the oil out. You do a wash. You inject antibiotics, and then come back later. So it's either one of those two things. I don't think anyone knows what the right answer is. I think you can make arguments for each one. And so I'm excited to hear what you guys decide.
Yeah. So we actually, because he didn't have pain, we thought this could be like post-inflammatory or post-medication. And I had basically direct contact with him, and he was not having issues. We figured that this was likely inflammatory, but I basically followed with him every 6 hours, and I saw him the next day to make sure. I evaluated pictures of him throughout the day and the night, and then stabilized him. And after a couple of days of not having pain and this remaining stable, we continued steroids and managed him as an inflammatory post-surgical inflammation. Although like with very, very close follow-up, and I was actually extremely nervous throughout the whole process of it. And he cleared up well. We didn't think the time course was right, and there wasn't any pain. And we already knew that we had a lot of inflammation in the eye, so we thought that was kind of leading up to this. But tap and inject would have been totally reasonable. He's very reliable, so we followed him. I was basically getting pictures of him every, basically like later on that day, that night. Saw him the next morning.
In that scenario, you're doing the right thing where you're trying to decide between the two. I think, watching him super closely, and being ready to pull the trigger is reasonable.
Yeah, but it was very uncomfortable. It was a very uncomfortable feeling for sure.
When you're the fellow who has to watch him, it definitely is.
Yeah. And so he, he stabilized. And so about 5 months after this surgery, his retina had been flat and we wanted to take the oil out. So what we decided to do was oil out and cataract surgery. And so, I think this kind of comes to the last points of, I'm trying to incorporate some of the things about teaching and about fellowship, and this comes to kind of adaptability as well. So we take the oil out and do the cataract surgery. And you'll notice that there's zonular weakness there. And I didn't think it was going to hold a CTR. I didn't think a sulcus lens was going to do well. So we talked about it and we decided to put it in acryos. So we picked out an acryos as we have stock. And I went for a scleral fixated IOL for him. We felt like he would do best with that. And we didn't have any plans to put in gas. I think if we were going to tampen out this eye again, it probably was going to be oil.
Can't be a fellow presentation without one sulcus fixated IOL.
Yeah. That's right. I had to. So, and then we did it. I've gone back and forth between doing these temporally and superior. Temporal, like if you're not going to put all the sutures in immediately, it's a very kind of natural way to put it in, but you have to switch your seats. So like, these days I usually just put it superior and put all the sutures in, all the Gore-Tex sutures in first, and then just put the lens in. I don't find that we get spaghetti like that. But this is another way to do it, which also works, although it's maybe a little bit harder to pull the sutures through with the lens already inside. And so
what forceps do you use?
To put the lens in?
To externalize the Gore-Tex.
Oh, I grab it with the max grip, you mean? So basically like it's MST to max grip, or max grip to max grip forceps for the when I'm pulling the sutures through.
Yeah, I used to bend the max grips, but I really actually like the Pinnacle scleral fixation forceps. It's already pre-bent and it has a nice grasping for a platform.
Awesome. Yeah, I've been getting a lot of stuff for our OR, so maybe I'll add that. Yeah, exactly, because a lot of times you end up having to bend the forceps and kind of bring them in. So this is my last photo of him. This is a few months back. Retina's flat. Vision is pinolling to 20/150. Pressures, there was a period of time when the pressure was low. The pressure's been controlled, and he's doing well. So I still talk to him, I still text back and forth with him, but he's basically continuing care with his local provider, and so we kind of have a group sort of text chat that we discuss. And all in all, he's doing reasonably well, I think. So, I think a few key points, and we're going to say a few things for the fellows. I think, we're all going to grow through fellowship. There's going to be valleys and there's going to be peaks. Probably the point of greatest acceleration in your training is going to be as you go from a valley to a peak. That's when you're learning and integrating the most. So you'll know that you're accelerating even if there's setbacks. You know that you're going to be accelerating and you're about to shoot up in terms of your surgical skill and knowledge.
Well said, man.
This is very good. I think this is a pretty good senior send-off. What do you think, Sunil?
I think it's pretty good. It's hard to believe these guys and gals grew up on Cobra, which is great. It's nice to see.
Yes, no, we appreciate the fellows kind of putting themselves out there because it's not easy to show some of these hard cases, decision making, and then a whole bunch of us just second guessing them the whole time. But hopefully it's done in good spirit at the end.
And you will continue to do this to yourself when you're out there on your own. And I know I do this. I have to admit, I send cases, images and videos to Prithvi, and he and I chat about cases that we work on, and we are critical of each other's work. And it's a good process to go through, and I hope you guys will continue it. It's a really important way to become a better surgeon.
Great case.
So we have our next Cobra rounds on August 7th. So bring in all the new retina fellows to join us. And Sunil, we have something going on at AAO.
Correct. We'll have Cobra live again at AAO. So we're looking forward to that. And hopefully we'll get to see everybody in person, which would be fantastic. Special thanks to Bausch and the iVista team. Prithvi, take it home, man. You get the final word.
Yeah, graduation coming up for our fellows. It's bittersweet to see them go, but wishing all the senior fellows out there great success in the future. Glad to call you guys colleagues.
Well said. Have a good night, everybody.
Have a good night.
And thank you, Kat. Thank you, Darius. Thank you, Alex. Thank you, Subit. Thank you, Steve. I think you're on at East.